How are you, everybody? As Ben said, thanks, Ben, for the intro. My name's Shauna Malloy. I work alongside Chris in PICU in Belfast, the Royal Belfast Hospital for Sick Children, and also a member of the retrieval team in Northern Ireland. So today I'm going to talk to you about status epilepticus, which I'm sure everyone's pretty familiar with. Really chat about what's new and what's happening next. So I'm going to introduce a case. So this is a true to life case. So it's a 3-year-old little girl, 14 kilos, background of juvenile idiopathic arthritis and non-verbal autism. No real issues other than that in the background, full term at birth, received all immunizations. This little girl presented with her first seizure to ED via the ambulance with a right-sided focal seizure. She had already received 1 dose of buccal midazolam via Northern Ireland Ambulance Service and on presentation was still actively seizing. So I'm going to try and introduce a bit of Slido here as well. So if you just want to scan the code and just tell me, what would your first thoughts be in terms of what would you do first with this child? Would you take a full history from the parents? Would you get IV access? Or would you assess their airway and breathing and make sure everything's good? Got an 111% there. So, yeah, so I think the resounding overall topic there is that you would assess their A and B and make sure the kid's adequately breathing. So continuing on, the seizure did terminate after 37 minutes. She had 2 doses of benzos and was loaded with Keppra. PICU were informed at that time and the retrieval service were kept up to date. They chatted it through. Because of the atypical nature of this and the new seizure, there was a decision that a CT brain was probably the best clinical pathway for next. But the child is only 3, so they thought it'd be better to still take good images to intubate the child. So the child was RSI'd, fentanyl, propofol, and rocuronium, and all was very straightforward, grade one airway. The scan was normal. The bloods were all normal. She was covered for any CNS infection with ceftriaxone and acyclovir. After the scan, again, there was further discussions with the regional PICU. PICU advised at that time that perhaps it might be worthwhile, if the scan's normal, that we lighten up the sedation, perform an LP, and then if the child was neurologically appropriate, and then advised to wake and potentially extubate. Sagamidex was administered by the anaesthetic team, but when the child was assessed by the local pediatrician, was found to have an abnormal neuro exam, and they weren't really happy to extubate. So the child was put on sedation, morphine and midazolam, and was accepted by PICU. So the initial call was at about 4:15 in the afternoon, and the child was accepted at about 5:05 following this abnormal neurological assessment. There wasn't, unfortunately, an ambulance available till 7, and this ran into the changeover with the nighttime transport nurse. The local team were updated, the child was stable, they were okay to wait. So the retrieval team departed at about 8:20 and arrived at 9:20. So when they went to child was still in theatre. There was a full team around paediatrics and anaesthetics. The handover was received and parents were updated. And whenever the child was being packaged and transferred onto the trolley, she spontaneously moved her hand up towards the ET tube and attempted to pull it. Moved all 4 limbs and attempted to sit up. So what would your thoughts be now if you were in that theatre? Would you think, oh God, I need to bolus propofol, sedate this child, crank up the sedation, this child needs to move to the PICU? Or would you think to yourself, that's pretty neurologically appropriate. Maybe it's better off for this child to stay in the local hospital and think about extubation. So very heavily on the appropriate neurological actions, maybe we should think about extubation. So keep this in mind and we'll chat about that towards the end of the talk. So basically today I'm just going to, our learning objectives mainly are what is pediatric status epilepticus, very familiar probably to us all. What's changed really in the clinical management of status over the last couple of years? And we're stable. What's next, or what's new? What new evidence is out there? So status really can be defined as a critical medical emergency. Its definitions have changed throughout the years. Initial seizure greater than 5 minutes, or repeated seizures, or clustering as we call them, without recovery of GCS in between. The incidence is around 17 to 23 per 100,000 kids per year. And unfortunately, although it is quite common with a common scenario in all our hospitals, there is still significant morbidity and mortality associated with status epilepticus. And unfortunately, as the seizure progresses, the chances of the drugs working decreases, and you run into issues with neurological sequelae. And the mortality is still 2 to 7%. This is not an exhaustive list of common causes of status. You have your known and your unknown. This ranges from structural, tumors, head injuries, mentioned before in Chitter's talk, infectious, meningoencephalitis, cerebral malaria, which we don't really see too much of around here, tuberculosis, metabolic issues. Is there electrolyte imbalances? What's your sodium? What's your sugars? Is there any issues with encephalopathy? Are you an organ failure? Think about your liver function. Metabolic disorders. Has this child got a known metabolic disorder? Is it very young? Is this a new presentation? Toxicity. Is this child a known epileptic? Do you need to think about your anti-seizure meds withdrawal? Is there any history of alcoholism or drugs, which would be more in the adult population, but as you know, it's becoming more common in our pediatric population and our adolescents. Inflammatory causes, genetic, Dravet's, Angelman's, Rett's, and febrile convulsions, which we're probably all very common with, quite common between 6 months and 6 years of age. And of course, you have your unknown reasons. So you need to think about this list really whenever you're thinking about what investigations to consider. So your baseline bloods, think about your bone profile, your calcium, your magnesium. A simple gas can tell you your glucose. If it's less than 3 millimoles, treat. 2 mils per kilo, 10% dextrose. Think about your is there a background here of, is the child febrile? Do you need to do a blood culture? Do you need to think about normothermia? Is it a febrile convulsion? Is there any evidence of toxicology? Have you taken a good history? Is there anything in the background that would suggest poisoning? Is this child very young? Do you need to think about your ammonia? Is this a metabolic condition? Think about MCAD, your plasma amino acids, your inorganic acids. Is this child a known, does this child have a known seizure diagnosis? Non-compliance is a very common cause of these breakthrough seizures. So you need to take your drug levels for your anti-seizure medication. We're always quite eager to do a lumbar puncture in these kids because you're worrying about your CNS infections, etc. But remember, you shouldn't immediately LP a child after a seizure because there's always risk of raised ICP and potential coning and death, as you know. And a normal CT does not rule out raised ICP, and that's why your neurological examination is so important. Whenever even after intubation, you need to do a neurological investigation before you stick a needle in that child's body. And then your EEG is probably down the line. So brain imaging, we're quite proactive with asking our DGHs to perform a CT of the brain. But when should you consider brain imaging? So in a lot of the cases, whenever the child does not have a known epileptic process going on, we would really advise for a CT brain. If it's a new prolonged seizure, atypical or focal, if you have any signs of raised ICP, sunsetting, anything abnormal in the background history in terms of your neurological examination, anything in terms of that would be suggestive of a spaced occipying lesion like a tumor, stroke. Does this child have a blocked VP shunt? Do you need to talk about to your neurosurgeons? Do you need to get a time critical transfer? If there's any history, yes, you have febrile convulsions, which there would be your child would have a temperature. But is there any evidence of a CNS infection and neuroimage with suspected meningoencephalitis? And of course, as Tudor alluded to earlier, always think about your non-accidental injury and your trauma. And of course, if you don't have a clue what's going on, you'd like to see what's happening in the brain. So this is the newish guideline. This was published in 2022, and it's a medical algorithm now for status epilepticus. It's in 4 steps, and I think we can all agree it's a much faster paced guideline. And of course, sometimes we just can't keep up with the actual steps. The emphasis really with this guideline is whilst completing each step, you must reassess the patient from an A, B, C, D, E perspective, considering all the reversible causes and preempting and preparing for your next step. Now, you've probably all seen this and been very familiar with it, so I'm not going to labour it, but I'm just going to talk about the differences between it and the previous guideline. So in terms of steps 1 and 2, there is a shorter 5-minute interval between your benzo doses. Now, your benzodiazepine drugs of choice would be your buccal midazolam, your rectal diazepam, and your IV lorazepam, pending if you have IV access. Now, these are used because they are licensed for kids, they're good onset of action, fairly easy to use, and your first dose is fairly well tolerated and can be given by a trained carer or in a pre-hospital setting by a paramedic. There is evidence to say that if this first dose is given within the 20 minutes of the seizure, you have a 70 to 86% chance of that seizure terminating. Unfortunately, as your time increases with your interval between your second dose, that actually reduces to about 17%. And obviously, you have your side effect also of benzos that it does cause significant respiratory depression and can cause hypotension. So although the first dose really is tolerated, whenever you're given the second dose, it's probably recommended that this is given by someone who has somewhat some airway expertise, because you can cause respiratory depression with the second dose of benzodiazepine. Step 3, the second line drug is Keppra. So as Costas alluded to earlier, the concept and Eclipse trial showed that Keppra was of similar efficacy to phenytoin, fosphenytoin. Also similar efficacy to your phenobarb and sodium valproate. The reason it's used is that it's a lot nicer drug profile. It's a cleaner drug. It can be given over 5 minutes. It doesn't have any issues with hemodynamics. Your hemodynamics are not affected. You don't need to be monitored. And as with sodium valproate, there is issues with teratogenicity. And although we don't really think about that in children, there's no contraindications to giving Keppra to a child who potentially could be pregnant at childbearing age. Also, the fact that there's no contraindications, whereas you need to think, if this child has a diagnosis of epilepsy, are they already on phenytoin? Whereas you wouldn't give phenytoin, you would give phenobarb, so you can give your Keppra freely. That's all within probably the first 20, 25 minutes, so it's fairly fast paced. Step 4, really then, if the team are ready, as I said, you're prepping for your next stage. At this stage, which is probably about 30 minutes in, if the team are ready, you're going to progress to an RSI to break this cycle of seizures. As I said, time is neurological sequelae, so you want to stop this seizure before any neurological problems can occur. Now, as we know, it might be okay in a PICU who are quite familiar with intubating children, but that time passes pretty quickly. And if you are ready, proceed with an RSA. And the induction drugs of choice, usually would be ketamine if there's any hemodynamic instability, and propofol is probably what most anaesthetists are most familiar with rather than thiopental. Your muscle relaxants of choice, I would say, would be rocuronium. It's got good drug profile, minimal side effects, good onset of action, 1 to 2 minutes, and lasts about 20 to 25 minutes. So if you're thinking about waking this child up for neurological assessments, it's a good drug to use. As I said, this happens pretty quickly. So if the team aren't ready, then you would proceed to your phenytoin or your phenobarbital if the child's already on phenytoin. And that's given over roughly 20 minutes. So you're buying yourself another 20 minutes. There isn't really evidence to say which is going to work the best here, continuing the drugs or the RSI, but it's something to think about. And then if your child's still seizing after this infusion's finished, then you proceed to your RSI. So to pull the tube or not to pull the tube, that is the question. And I know that in the national guidelines would be to say that all children would be transferred, informed by the retrieval, you would inform the retrieval team and transferred to PICU. But this really isn't what's happening throughout the UK. And I can't say that in Northern Ireland because the majority of patients are transferred to PICU. And with that, I know this is a fairly controversial issue within Northern Ireland, but having having done my transport in England, worked with Costas, this would be a fairly normal, would I say, happening that they would consider extubation if specific criteria were fulfilled. So I'm not here to be slated for whether or not this should not happen in Northern Ireland, but I want to just present new evidence that has came forward. So this is a paper that was published in March 2024 in the Archives of Disease for kids. It is a new piece of research which shows really what the baseline clinical characteristics of these kids are, predictors of successful extubation at the referring hospitals, and the short-term outcomes of kids intubated for status epilepticus. Really, it's from 10 paediatric retrieval areas throughout the UK, and it's telling us what is happening and what's the difference from the national guidelines. So there was 1,600 roughly referrals for status, and about 1,136 were intubated. Of this 1,136, 396 were extubated locally. Of these 396, 19 were re-intubated at the referring hospital. Of these, 7 were re-intubated because of recurrence of seizures. 7 were re-intubated because of reduced GCS, respiratory depression, and 1 for laryngospasm. So you could argue that these potentially were avoidable re-intubations, and then were unknown in 4 cases. The factors associated with not extubating the child were set out as infectious or metabolic cause, CT changes on the CT, any preceding encephalopathy, the sedative associated with midazolam, child will wake up, and the use of secondary anti-epileptic drugs. So the research from this showed that regions with the highest rates of local extubations have guidelines with detailed and agreed criteria, and there are regularly audited outcomes. So there's guidelines to say which children should be considered for extubation and which children should absolutely not be considered for extubation. And these are just a few that I've found on the internet, from NUTS, where I did my training, from CATS in London, and South Thames Retrieval Services, and they can be found if you just Google them. Interestingly, the PICUs with the highest rates, the PICUs within the regions with the highest rates of local extubations received the highest proportion of patients who remained intubated for greater than 6 and 24 hours. So that would indicate that there was an ability to successfully identify patients who you could extubate earlier. Conversely, the PICUs in the regions with lower rates of local extubations had the greater proportion of these patients who were intubated for less than 6 hours. So perhaps they were the patients, there was a large proportion of patients there that could be extubated locally. As a lot of the time we know in PICU, usually extubate them after a lumbar puncture if we feel that their neurological examination is appropriate and there's no red flags to say that they need to be intubated. There is criteria in all these guidelines of what children you should consider for extubation. And as you see, this is the guideline from the South Thames. There's 10 points here. The kid was intubated for low GCS or hypoventilation, their seizures controlled, no new findings on CT. You can read them. We have sent out a survey among Northern Ireland, and interestingly, one of the main things that came from that was that there was a lot of anxiety about where these children were going to be looked after and recovered, essentially. There is, as we know, our resources, we don't have great resources, we have minimal staff. Who's going to look after these children while they recovered after being intubation? So that adequate clinical support available post-extubation is a big area that we need to focus on in Northern Ireland if we're going to move forward. With these guidelines also, there is a clinical assessment that needs to be fulfilled in terms of your respiratory, your cardiovascular, and your CNS. So there is a lot to think about in terms of what children can potentially be extubated. But it is happening in parts of the UK, and it is something we can think about. So in terms of our case, the retrieval consultant made the decision to extubate the child regardless of onward transfer. So they potentially were going to take the child with them, even if the child did not have a tube. Put on the bag and circuit, was breathing spontaneously and opened her eyes to voice. Sedation was stopped. The neurological examination, as you can see, was very appropriate. They didn't do a lumbar puncture at that stage. They gave 5 small dose of propofol just to facilitate preparation for extubation and for a safe extubation, and the child was successfully extubated. The retrieval consultant was present throughout, so give the local DGH a bit of confidence of, if things headed southwards, and chatted to the paediatric consultant about whether or not this child could remain within the local DGH to save the transport and the family anxiety of transferring to a paediatric intensive care unit. And the parents did confirm that the child was back to neurological baseline, and the retrieval team departed after 30 minutes. The child had no further seizures during that admission. MRI was normal, and there was an EEG performed, which was suggestive of focal epileptic process. But considering that there was no further seizures, the child was discharged with routine follow-up. So, in summary, the guideline for status epilepticus, it's a newish guideline, which we should all make ourselves more familiar with if we're not already, in 2022. And I think we can all agree it's a much faster paced guideline, and you stumble upon your RSI quite quickly. Pre-hospital benzos are encouraged and endorsed. The faster you get that first dose of benzos in, the higher chance that the seizure will terminate with less chance of neurological sequelae. There is new evidence out there to suggest that extubating locally follow RSI for status epilepticus is safe. Now, I know there is no current guideline for Northern Ireland. We have sent out surveys, and we're looking at all the responses in terms of just our local practice. And it's nothing that's going to happen overnight in Northern Ireland, but there is a guideline in the pipeline. And there is a potential for introduction at some stage in the future, perhaps introduction initially whilst a member of our retrieval team are present. These are just some of my references, and thank you for listening, and just happy to take any questions. And that is the code for feedback and my email if anybody has any pressing questions they want to ask me. Sorry, I've spelled, there's two T's, Belfast Trust.